Good morning, good afternoon, good evening to everyone. We'll get started in just a few minutes to give others a chance to join. But while we wait, please feel free to introduce yourself in the chat and let us know where you're joining from. We'll begin shortly. Hello again to all of you, wherever in the world you're joining us from today. We're glad you're here. My name is Emily Hirata, and on behalf of the Adventist Development and Relief Agency, otherwise known as ADRA, along with support from the Global Nutrition Cluster Technical Alliance, I would like to welcome you to today's webinar on ADRA's MAMI pilot implementation in Yemen. Before we begin, just a few housekeeping items. We ask that you please keep yourself on mute for the duration of the webinar so as to minimize disruptions to the presentation. If you have any concerns, please feel free to put them in the chat. We will also be having a Q&A session at the end of the presentation, so please do post your questions there in the chat as well, and we'll try to get to those and answer those as best as we can. Today's agenda is as follows. After this welcome portion, we will get an overview of the Yemeni context, an introduction to what MAMI is, and then finally, we'll learn about ADRA's MAMI implementation in Yemen, followed by the Q&A. Our presenters today are the following. Myself, Emily Hirata, Technical Advisor for Health and Nutrition at ADRA International. I provide support to ADRA Yemen's USAID-funded nutrition programming and am giving the opening and closing of today's webinar. Our main presenter today is Dr. Ahmed Al-Jabi, our Senior Nutritional Advisor for MAMI in ADRA Yemen, based in Aden, Yemen. We also have Alice Burrell, Senior Advisor for Emergency Nutrition MAMI at Save the Children. Through this role, she provides support to the Global Nutrition Cluster Technical Support Team and has been providing technical assistance to ADRA during its MAMI pilot. Alice will be chiming in during the Q&A portion as needed. Today's objectives are twofold. We not only aim to share what we've learned from our MAMI pilot program in Yemen specifically, but we also hope to contribute to the wider MAMI programming community and information base globally, beyond Yemen alone. And with that said, I will now turn it over to Dr. Ahmed to take it from here. Dr. Ahmed, the time is yours.
Thanks a lot, Emily, for this wonderful introduction. Greeting for everybody, Dr. Ahmed Al-Jabi, Senior Nutritional Officer, MAMI, ADRA Yemen team. Welcoming everyone. I will start my presentation with discussion about Yemen context. As you might know, that Yemen location in the western of Asia, in the south of Arabian Peninsula, occupying an area of 530,000 square kilometers, population more than 31 million person with an annual growth rate 2.5. Yemen now one of the worst humanitarian crises. About more than half of Yemeni people experiencing high level of acute food insecurity, with about 4.5 million people displaced. 77% of these people are women and children. According to the Global Hunger Index of 220, show that from 116 countries, Yemen ranked 115. Only Somalia below it. As you see, we are now in a high degree of alarming, recording a score of 4.5 on the hunger index. It's a critical one, so need many intervention for Yemeni. As you see from the map, Yemen is containing too much borderline coastal lines with many different landforms, desert, mountains, and other. So they will be more difficult for communication and connection sites and providing the service for these people. Next slide, please, Emily. Now we will discuss about we are discussing about Yemen context, infant and mothers. We will start it with the infants. As we see, there is 23% of the total admitted cases of TFC is under 6 months of age. 15% of exclusive breastfeeding only. It's while converted with the target nutritional, the global target nutritional, which will be more than 15%. Here in Yemen, we're having only 15%. So also we're having the second point is the low birth weight. It was just estimated. We have only late estimation date on 2020 and 2010. Now in the present day, there is no estimation, actual estimation. It's reaching about 32%. The target, the global nutritional target is below 13. Children under 5 with underweights, the percent is 44 in Yemen. This is regarding the infant context. The mother is also having many defects in their surface. For example, we're having in delivery which occur in the health facility, 13%, 15% delivery take place at home, which below than what we need actually to have. About mother which are receiving postnatal care, we have 20%. Also, the delivery occur with under a risk condition. There is no skilled caregiver. We're having a 55%. So this all means that we're having a defect in the surface in Yemen, which are needing the intervention and the help for Yemeni people as a whole. Next slide, please, Emily. Here we'll discuss a general information about MAMI. What's the meaning of MAMI? MAMI actually as a preservation is a management of small and nutritionally at-risk infant under 6 months of age and their mothers. Next slide, please. Here the vision of MAMI, we will discuss here about or dealing with every small and nutritionally at-risk infant under 6 months of age and their mother is needing for support to survive and thrive. We meaning by survival that they reducing the risk of death. Also, the threat here will reduce the risk of illness. We're reducing the poor of the health, malnutrition, either the infant or the mother or the caregiver, improvement of development and long-term health. The approach of MAMI in general, we're having approach guidance to hospital case management at risk infant under 6 months of age through community-based, which meaning that we will concentrating on the infant and the mother as a pairs. We don't usually dealing with infant alone and the mother alone. We dealing with them as a pair. The other point here in the approach, the leverage and the building on it what already existing, which meaning that we will strengthen the already existing program in the communities on surface, like reproductive health, like nutrition, and the health sectors. We will give some strengthening for this program. We will make some connection with them. After that, we will link mother and baby to the existing surfing and linking between each other of these systems. For example, after vaccination, what is the rule? What we discover, we put them in same table with CMAM program and supplementary food program for the mother and others. Next slide, please. How to identify small and nutritionally at-risk infant under 6 months of age and their mother. Actually, we're having some criteria and criteria for the accepting and for finding these infants and their mother. They're having some what we call it spots or some features that we are looking for it. So this specific group under 6 months of age and their caregiver or mothers, they are having some features like when we during the routine measurement for MUAC from the volunteers, we will check the MUAC for infant, also weight for age Z-score for the infant, weight for linked. It is also used in our health facility for assessment. The feeding risks, which meaning that the infant feeding problem, that the infant having a problem with feeding. The infant cannot take his breast milk from his mother or take it incorrectly, by having a problem with his congenital problem, tight tongue, cleft palate, and some congenital disease intervening with the breastfeeding. Also, if the child having some sore throat, he having a candidal infection or other, we screen for it and catch like these cases. Also, mother feeding problem. This is one of the important point or risk we are seeking for it, which meaning that the mother cannot give her milk to her infant during his 6-month exclusive duration, 6-month duration. The mother may have some mastitis, which is meaning inflammation of her breast. She must having some crackles in her navel, bloody navel. She cannot give her infant the pure and the enough milk. So we discover these cases and deal and manage this. Also, maternal well-being risk, maternal mental health. As you know, we are in a conflict area in Yemen and other place we are intervening. There will be need for some mental care for illness. The MAMI general risk factor, which meaning maternal orphan or the mother is absent. There is no mother to take care about this infant. Also, this is we are seeking this group. We're seeking to giving the advice and supporting for this group. Also, low birth weight, premature birth weight, multiple birth, twins, 2 twins, 3, and others. Maternal malnutritional states, also the maternal disease, excessive crying or sleeping problem, infant with colic pains. Also, this is one of our risk factor to catch it and deal with it. Next slide, please. Now we will explain how we supporting the small, how in MAMI we supporting the small and nutritionally at-risk infant under 6 months of age and their mother. What is the mechanism of our working? How we are working here, we will explain it at a general point. The counselor on the core topics for all enrollment pairs. As we mentioned before, that we will make some enrollment for the infant and whose caregiver, mother or others in our program. We will give them an advice. We will give them tailored counselor and action to address a specific risk factor and the problem that I mentioned before in the before slide, that we will make some exception or some choosing of these cases. After that, we make enrollment and give them. Also, some cases need referral, as which is a severely nutritional risk having, which means have some edema or having some risk factor that the infant cannot take his milk at all, continuous vomitings, and this criteria which are using in the triage in the IMCI. Also, we continuous after we enrolling this infant and his caregiver, mother or other caregiver. We continues to monitoring in our program enrollment the mother and infant pair. We take their weighting in every visit. As we mentioned, we appointing a visit for them either 2 weeks, 1 month. What is depending on criteria, specific criteria we have deal with it. Continuous monitoring, as I mentioned, pairs and progressive and well-being at each visit, with the visit frequency reduced, which meaning that when we see that these cases of infant or this enrollment cases having good improve, we make the distance too much for it. Next slide, please. Now we're reaching to the point, the important point, that what is ADRA? This point we want to show you that what ADRA do for MAMI and why we choose this. Actually, ADRA since the needs and the gaps in this specific under 6 months of age grouped. So ADRA started to plan for the implementation with a close coordination with the Ministry of Health and the supporting of glomerular cluster nutrition with the guidance of technical advisor Alice. ADRA accomplished the MAMI pilot implementation in Yemen We started it at December 2021. We do many activities. We started with the training of 18 health worker with 58 community health volunteer. We try to use to activate it community level and health facility level and joining together. Here in ADRA, there is many country do this experience, but they try to use it as individual. They're using the health facility or using community health worker as alone. But here we ADRA, we try to join them together to give a good service for this project. So we train this community health worker and volunteer in 9 different sites in 3 different government. I will explain later. And these places also we provided our MAMI community health worker with a kit, a specific MAMI kit, which is primarily preventing on others kits which are available for other volunteer that we using that we give them or provide them with pediatric skill, which is help in the waiting of the infant at homes, at their places, at camp and other places. Also provide them with a thermometer to take the vital sign, stopwatch to recording the pulse and the respiratory rate of the infant. This helps us and gives us good important information regarding the critical infant cases. Is it needing referral, urgent referral, or it can continue and referral for the health facility and other. Also, we train them and and provide them this. Okay, next slide now, please, Emily. Okay. After we starting the implementation, we must we having many decisions how we will start this implementation on the plan for implementation. Actually, we having many choices for that, but we try to take the shortage and the way that will help us to get our target. So we started to screening, as you see from the pictures here. From this schedule that we starting with screening community health volunteers, and now we are attending to ICCM to integrate it with the ICCM volunteers and reproductive health volunteer. Try to make some integration with our program to help us to how to catch and find these cases. After that, after this, the second level will be at the health facility. MAMI assessment. The MAMI assessment will be at the health facility. We have chosen health worker and midwife, which are we supporting in this health facility. After that, we will see the triage of these cases. If it is having a risk factor, as you see the red color, which diagramming that this cases is a severely nutritionally risk cases, so needing urgent referral for the TFC therapeutic feeding centers. We having a criteria for that. If it have a specific sign or a specific MAMI sign, which meaning that having edema, having edema and at any degree, +1, +2, +3, any degree of edema of under 6 months of age. Also, if they having they cannot take his milk or breastfeeding at all, continuous vomitings, having any other IMCI dangerous sign, this need urgent transfer to the TFC. At the level of health facility, our outpatient care, we here accepted the moderately nutritionally risk cases, which having a criteria, which are there is a failure in the growth deficiency, having MAMI specific risk factor, also feeding challenge and moderate maternal health and other. Also, this will be dealing at the outpatient level or health facility level. After that, continue till the infant reaching 6 months of age exactly. When the infant reaches to this age, we do a reassessment for these cases and see if it is good for it. We can exit it and send it for the community, at the post community to follow there. Or we can send it to other program, existing program, as we mentioned before, like supplementary program for the mother, or some outpatient or inpatient, whatever the criteria fit on it, we can refer it to it. Also, the green one will be mentioned or dealing with the low nutritionally risk cases. Here we will deal it at the community by following by our volunteer. They will following the weight, following the development and other. So we try to complete this circle, and as I mentioned before, when it reaches 6 months, we will refer it for other existing program. Thanks. Other slide, please. MAMI pilot sites. Here, as you see in the map, the 3 different government that ADRA choosing for interval, we are interval in it. So as you saw from the map, that at Tuban and Al Madariba in Lahej government, we having 6 community health worker in 3 different sites, Bir Nasser, Al Migza and Al Hubayl. We having 6 health worker, trained health worker, and about 12 community health volunteers. Also in Abiyan government, also we are in Kamfar district. Here we having 3 different health facility. We having Al Jola Shabiya, Al Code, and Al Dirjaj. All of them, 2 of them is health units. The only one is Al Code, which is maternal. We call it Central Health Unit, Maternal and Child Central Health Units. Also in Lahej, 2 units. In Al-Dali', we having in Al-Dali' government, we having 3 sites in Al-Dali' city. We having Habil al-Suq, we having Al-Bajah, we having Al-Fajra. All of them with in Al-Dali' government 6 health worker, between health worker and midwife, as I mentioned before. Also, we having 20 community health and nutritional volunteer in these sites. As a whole, we having 18 trained MAMI community health worker and 58 community health volunteer now are working with MAMI implementation sites. Next slide, please. ADRA MAMI management process. Here we will explain for you what is ADRA do specifically after implementation of MAMI. How is the processes here? We do it. How we do it in the community level. How we do it in the facility level. In the community level, actually we're starting with our community health volunteer with screening cards, which containing the risk factor and the criteria for enrollment for MAMI program. After that, if we see there is a dangerous sign or is the needs for a transfer to the outpatient or it's fit for our criteria, we transfer it for, we refer these cases through forms to the health facility. During that time, there will be a register from our community health volunteer. We register cases that are sended or examined by, screened by them. After that, at the end of the month, we collecting the monthly report or the cases and the reason of transfer of it. At the health facility level, there will be a reassessment or a complete assessment for the case. We're having a form for this case, for this assessment. Health worker, after assessment and having the criteria, there will be enrollment and follow up these forms. This takes till the infant, as we mentioned before, reaching under 6 months of age. During this time, there will be a register. We're having a register for these cases. At the end of the month, we're having a monthly report to follow up. Next slide, please. Finding according to the information collected from the pilot health facility, we use this data to be analyzed and see what is what is the defect that we're having, what is the information, what is the importance of this information, and how we can deal with it. Next slide, please. Our finding that depending on the collection data from the beginning of December 2021, started at December 2021 till March of till the end of March 2022, which meaning 4 months of collecting of data. Actually, we're having about 380 cases divided by percently 43% male and 57% a female category. As you see from the diagram in front of you, that we divided the age under 6 months of age to 6 different groups, below 1 month, below 2 months, and further in. So as you see from the diagram that we receiving, the maximum cases was below 2 months of age. Next of it is below 6 months of age exactly. This is nearly the age of all group that we accepted in our enrolled in our program. Next slide, please. Here the enrollment criteria. The enrollment criteria, that how we accepted these cases and in which forms, which meaning that I having a growth deficit for accepting. How is the person in each government in Abiyan, Abdallah, and Lahaj as a total. Also low body weights, premature, feeding difficult, mother illness, multiple birth, orphan, adolescent mother. We recording and collecting this data according to it. As you see from the diagram, that the growth deficiency is with a maximum recording cases. After it is feeding difficult, which are more second maximum counting. The minimum one was the orphan cases, as you saw from the percent. Okay, next slide, please. Okay, here we make some vast difference or comparison between the enrollment and existing. Actually, we're having in Abiyan about 141 cases enrolled. The existing case till now is 21. In Abdallah, we have enrolled 108 cases. Exit cases is 17 cases. In Lahaj, we're having enrollment 131 cases, equaling 33 cases. At a total enrollment, we're having, as we mentioned before, 380 cases. Total existing is 71. Now we will discuss. We will try to explain you how the existing of our program. As we mentioned before, that when the infant reaching under 6 months of age exactly, we make a reassessment for this infant and try to deviate them or refer them to the suitable program on the criteria if it is fit on this infant. Next slide, please. Case of referral. Here we divided it, the exit, as you see. The exit of case go to the post communities with a percent of 48%, existing to the other program. Example for other is outpatient, supplementary food program, mental health care, and post communities. The post communities will take the percent, as we mentioned, 48. The referral for other program was 52%. As you see, we're having the highest percent for referral for the SPC for the mothers with some nutritional defect in the mother. So we transfer. It's continue through our program, through our follow up. There is no complete improve for the mother nutritional state. So we will not stop at this point. We will advise her and referral her for joining or enrollment in the supplementary program. Also, we having outpatient. We having a percent of more than 10% as a range. These are actually the maximum and the minimum transfer. Next slide, please. challenge. We have many challenge in our implementation here in Yemen regarding the implementation of MAMI pilot implementation. Actually, one of the important challenge that we're facing, lack of the statistics data for under 6 months of age. We are looking for how many cases, how many have infant low body weight, how many have premature, how many we having data for the underweight, for the stunting, for the other cases. Actually, we have some lack of this status. We hope we can give some help in this basic line of data in the future. Also, we're having some lack of the tracing mechanism for the referral cases to the TFC, Pediatric Hospital and Psychiatric Center. We're having a very challenge in this point. Actually, one of our challenge that here in ADRA, we're having no intervention in the TFC center, the Therapeutic Feeding Center. We're only intervening in outpatient and community level. So now we have many plans for intervening and some connection with the TFC Therapeutic Food Center. Regarding the psychiatric centers, actually we have a rare center suitable for dealing with especially severe cases of mother mentality. We try to get over it by arranging with many government hospitals like As-Sadaqa Hospital here in Aden and other clinics. We're having also some logistic problem with poor network coverage and stable security situation. As you know, we are in a conflict and the economic collapse and other defects. So we try to get over it many times. Also, we're having absence of the clinic of mother with mental health condition, which meaning that some clinics in some district like Al-Dali' and Lahaj, some places, we interfere. We don't having actually correct specialized clinics there for giving advice and support for moderate cases. But we try to fix this challenge and support them. Harmful traditional practical. We have many harmful traditional practice in our community in Yemen. Home after delivery, the mother cannot get out from home, need some place, the evil eye and other. We try to give them change their personal, change their habits here. Next slide, please. Case study. For this two case study, we bring it from our from health facility. Next slide, please. The first study is a twins, a mother names Khulud, the name of the mother, having a twin, Mohsen and Tahani. Their age during the assessment was 6 months of age. During the routine visit for the health facility for vaccination, the mother bring the twins. The identification by a health worker, our midwife there, sent for MAMI assessment. The twins enrolled as MAMI cases and mother sent to the counselor corner for encouragement of exclusive breastfeeding to stop mixed breastfeeding and beneficial and explain her for the benefits of exclusive breastfeeding. During the assessment was at the month of 1.5 months, which equally 6 weeks. After 3 months of follow-up, the weight of Mohsen is in the beginning 2.7. After 3 months, it was again gaining more than 1 kilograms. Also, Tahani gains more than 1 kilograms. Length was 49 for Mohsen and 49 for Tahani. Weight for age was below -2. Now, after follow-up and 3 months of follow-up, below -1 to 0. Weight for age in both are same. Infant MUAC 10 centimeters for Mohsen, 9.6 for Tahani. Now, after follow-up and supporting, Mohsen 10.8 and Tahani 10.5 centimeters. Mother MUAC at the assessment time was 23.5 centimeter. After 3 month follow-up, she having a good improve with 24.3 centimeters. A feeding state, we assisted as a moderate risk for both twins, so we accepted them at outpatient level, give them advice for exclusive breastfeeding and assessment of the mother insurance of the mother, follow-up of the infant and mother, and improve case. Next slide, please. Case study number 2 was Nasser, a 4 month of age. He is second baby of Naima. His mother aged was 19 years old. She's brought to him to the health facility and complaining that he is not growing well because she thought breast milk was not it. The mother having a problem that she think that her baby cannot or not taking enough breast milk from her. So she bring him that to us and complaining that he is not developing well. After assessment, the age of the infant Nasser was 4th month. After 2 months of age, weighting was 4.4. After 2 months, it gained weight to be 5.6 kilogram. The length was 58. Weight for age below -2 and reaching to -1 to 0. Weight for length, Z-score was at the beginning or assessment, it was below -3. Now it is below -2. Mother MUAC was, there is nutritional state risk here for the mother. Her MUAC was 22 centimeters. After 2 months, it reaching 23.1 centimeter. Feeding says mother, I think she have not enough fooding. It is a moderate risk cases, so accepted in our program. Now the case after 2 months improve for mother and infant. Next slide, please. Okay, now reaching to the question for you, Emily. Thanks a lot, everyone.
Yes, thank you for that, Dr. Ahmed. Let's now turn it over to Alice and also our Health and Nutrition Advisor, Millian Marcos, for the question and answer portion.
Yes, I think over to Millian, who's been collating the questions. So Millian, if you can ask the questions, that'd be great. Millian, are you still with us? I know he was having some connection difficulties earlier.
Hello?
Hi.
Hello.
Over to you.
Hello?
Yeah, go ahead.
Hello? Can you hear me all?
Yeah, we can hear you well.
Okay. Thank you very much. This is Emilio Marcos. Unfortunately, the video is not working from here. We are facing some difficulties of the power fluctuation. But I have collected the questions. To respond on them. The first question raised by Colin Emari is, can you describe more the screening at the community level by the CHMVs and CMWs, which means community health and nutrition volunteers and community midwives? And how frequently does this screening take place? And how centralized or household level, what kind of tools are you using for this screening? This is a question from Pauline. It's all about screening. And there is a follow-up question from Eleanor Roges. It says, what were the main challenges you had related to community screening, and how did you overcome them? Did you adopt the MAMI care pathway, health workers materials for the community health and nutrition volunteers and the community midwives? So these are two questions from Colin and Eleanor. The third question is, what cutoffs are you using for MWAC to determine risk, and why are EBF, I think it is exclusive breastfeeding rates, so low in your operational area? This is a question from Hati Bato. And the last question that I have taken note of is on the admission and exits. Is there discrepancy between the admission numbers and the exit numbers? The admission was higher, but the exit was lower because many children are still in the program. The question is, were there a high number of defaulters? This is a question from Eleanor again. So to start up, I think I saw Dr. Ahmed Al-Jabi was touching some of the questions in his presentation, but to make more explanation, to explain more, so let us start from the first question. Can you describe more the screening at the community level, Dr. Ahmed? Then we will go to the next question.
Dr. Atma, you're on mute.
Hello?
We can't hear you. You're still on mute.
Yes, I will answer this question. Sorry, Emily. Actually, some defect with voice. Thanks a lot for this question. Actually, it is an important question. Unfortunately, I want to just mention it that we training our community health volunteer started at January 2022. The entrance of them in the service was started at the beginning of March. 2022. So we're having collecting data of 1 month, so we didn't enter it in. But in generally, our community health worker screened with MWAC during home visits, routine home visits. Also, they are using the growth cart for monitoring. We, as I mentioned before, we provide them with a kit, MAMI kits. This MAMI kit including scale and thermometers and other equipment. So they take the weights of the infant. They check if having dating for birth for these infants. Take the MWAC of the mothers. This all done routinely during their home visits. And generally, next question was. Yes.
I think you have addressed how frequent does this screening takes place, and how centralized or household level, or what kind of tools are you using for this screening?
Yes, regarding the tool we are using, we having MAMI, as mentioned. If can Emily return back the slides, please, to the showing number. No, before the slides that ADRA expressed just before the enrollment. Not the findings. Yes, this one. Yes, yeah, yes. Sorry for this. I couldn't see a number now. As you see here from the slide, we're having a form for the referral. We're having a form for the screening for the volunteer. Can you see it? Yeah. Screening card, which is on the top of the left side, designed by the We help in adapting them, designed by version 3. Version 3, yes, for MAMI version 3. We try to adapt it and translate it in Arabic and try to be with our context fit and adapted to our context. So can you see it? Okay. This is how the processes of ADRA processing in the community health level. We take the screening through the cards. After that, we see if needing referral these cases. If not, we roll it on the tally sheets, daily tally or monthly tally sheet. After that, at the end of the month, we register it in the reports of community health volunteers.
Sorry, what kind of challenges have you faced so far regarding this community screening, and how did you overcome?
Regarding the challenge in the community level, actually from the beginning, we don't have any other program. As you know that ADRA Yemen the first one who started this program in Yemen. So we don't have a qualified person or qualified community health workers and the form. So we try to prepare and adapt this form and community material for this volunteer to see what is the capacity of our volunteers and how we can strengthen it and how we can use it in the MAMI work. So after we starting the training, as you know, most of volunteers are using the MWAC and using the growth card, but using or examine fetal sign, it is a new option for them. So in the beginning, there was some fairness of them, but with continuous in-job training and visits for them, we discuss with them and explain them the benefit of examine the infant and how to deal with the infant actually and how to weight it. We train them on that, and in the job training, we make them trustful themselves and we get over it. We're having other challenge, but not related only with MAMI, also regarding the work of all volunteer. As you know, they are a female. They are contacting with the community, traveling from place to place in the village. As you know, we are in a conflict area with some communication defect with them, and we are a Muslim community, so there is some commitment on that. But our community and our people understand what we are doing here and trust us and encourage us after the understanding what you are doing here, that we are try to help them and discover the cases that needing intervention from our side. If Alice having any notes on that, can add. Sorry for.
Okay. No, that's great. You keep answering. I'm just here if needed.
What? Next question, please. Yes, Minion.
To determine risks, and why are exclusive breastfeeding rates are so low in your operational area? There are two questions.
Yes.
Cutoffs are you using for MWAC to
Yes,
determine
sorry.
the risks?
You are asking the last question. Sorry for that. Low birth weight and the slide
No.
17.
I said the next question is what kind of what cutoffs are you using for MWAC to determine risks, and why are exclusive breastfeeding rates is so low in your operational area? This question is from Hati, but so there are two questions.
Just a moment.
Dr. Ahmed, do you want me to repeat that? So what MUAC cutoffs are we using? Is the first question. Did you catch that?
Like for
do you answer that? I did quite the question.
Yeah, the cutoff point means I think it is a cutoff point. The cutoff point for MAM, like moderate acute malnutrition and severe acute malnutrition. That we apply for under 5 children. But I think in this question, it is the cutoff point for under 0 to 6 months children, or under 6 months children. What cutoff point, or the MUAC, like is it less than 11 centimeter or like 12.5? We have this classification in CMAM, but this is not CMAM. This is MAMI. Just what kind of cutoff point we use to determine the risks?
Thanks a lot for this good question. Thanks a lot for this question. Actually, the MUAC criteria here using as an experimentally, we use it as not confirmed criteria, but here we use this cut point as if the infant is under 6 weeks, and his MUAC was below 11. This is a point for us to accepted this infant. But if the infant is below 6 months of age and his MUAC is below than 11.5, which is the same criteria as for some patient and other CMAM which are used, we accept it also. But if the infant are above than his age is above than 6 months of age, below 6 months of age, sorry, and his MUAC is above 11.5, this is not accepted in our as a criteria in our program. If Alice having.
Thank you. Can you explain a bit about the reason why exclusive breastfeeding is lower in our operational area? Hello?
According to the survey, last survey in 2021, there is a decrease in the surface of the IYCF in generally in this area. So I think it is reflected on us also. It's decrease in the survey. So is our purpose in our program is strengthening this survey IYCF and give support, good support for it. As you see, one of our supporting and managing of these cases is a corner. This IYCF strength is one of our corner in the working. Thanks for this excellent question.
Thank you so much. I think let me ask you one more question before we close the session. And I hope the questions are becoming many now. But I hope the answers, we will reach out to those people and all the participants of this webinar with the answers for those questions after this webinar. But let me ask you one more question for the last time, which is about the question on the admission and the exit. Is there a discrepancy between the admission numbers? The admission number is higher, but the exit is lower because many children are still in the program receiving care, or is it because the high number of because of the high number of defaulters? Is it because of defaulters, or is it because of the discrepancy that has occurred between admission and exit?
Thanks a lot for this question also. Actually, as I mentioned before, this enrollment data or this finding was selecting for 4 months working, hard working actually. When you see there is a big difference between the enrollment cases and the existing cases, this is due to the low gap here. We are dealing from 0 to under 6 months of age, which meaning 6 months. If I discover it 2 months, 3 months, maybe 4 months, 5 months. So other program are dealing, like CMAM program, dealing from 6 to 5 years. It's a distance way. So you cannot find this difference like here in MAMI. The difference will be not clear. But in MAMI, you can see it. The enrollment is big and too much numbers, but the exit is low. So it is a normal result of this difference between MAMI and other program. I don't see any difference with it. Thanks a lot for your good question again. I think we have more 3 minutes for other question, if there is another question.
Yes, thank you so much, Dr. Ahmed Al-Dabi. I'm done with the questions for the timing. That means all the questions are not addressed because of the time. So let me give the chance to Emily or Sanjat to say or to take us through the next steps in the remaining few minutes. Thank you.
Thank you so much. That was a great presentation and a great Q&A session. It's really exciting to see everything that's taking place within ADRA Yemen's MAMI pilot. And we would like to encourage all of you, all of those that are participating in this webinar, to consider MAMI programming wherever you are, if that hasn't yet been done already. It's so clear that MAMI truly helps to fill some important gaps. And as MAMI continues to grow globally, we look forward to learning from you through future events just like this one. So before we close, I do want to briefly mention the GNC Technical Alliance support on the slide here. If you or your organization are in need of nutrition technical support, there is help available. You can request support from the GNC Technical Alliance by visiting their website at ta.nutritioncluster.net for remote or in-country support, consultants, and even quick advice. And this has been a really useful resource for ADRA, so we encourage others to make use of this as well, especially if you're working on a MAMI pilot like us. And you can also visit ennet.org for technical peer support too. And with that said, thank you so much to our presenters and to everyone that joined us for today's webinar. We appreciate your time, your attention, and your questions today. After this, you will be receiving an email within the next couple of days, including a recording of today's event, answers to the remaining questions from the chat, as well as a satisfaction survey. And we ask you to please consider filling this out as it provides us with important feedback and helps us in putting together future webinars. Again, thank you for joining us, and we wish you a lovely rest of your morning, your afternoon, or evening, wherever in the world you are. Take care, everyone.